final session of the Pediatric Hematology Oncology webinar series, the Biopsychosocial Model of Pain Management. Thank you for the time taking the time to join us this morning. I am Karen Long-Traynor, clinical psychologist in the Division of Pediatric Hematology Oncology at Rutgers Cancer Institute of New Jersey. Please note, everyone has been muted upon entry, and this webinar is being recorded. To participate in the question and answer later in the program, please submit any questions via the chat box at the bottom of your screen, and I will look at them at the very end. The learning objectives for this webinar are to develop multidisciplinary treatment strategies for pain for children with cancer and blood disorders, explain the interaction of biological, psychological, and social factors in pain expression, and discuss ways to present to patients and families the involvement of psychology in a pain management plan. Physicians are eligible for 1 AMA PRA Category 1 credit, and nurses are eligible for 1 ANCC contact hour for their participation in this live event. To receive credit, you must complete the post-webinar evaluation by Friday, June 30th, and this information will be shared with you via email following today's session. I want to thank the planning committee members for this webinar series. I have nothing to disclose. And the content of this presentation has been reviewed, and the views expressed are my own. All right. So today we're going to be talking about pain. And pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So pain is basically a fundamental warning system that our body has created to let us know when there is some sort of significant problem that we need to attend to. It is so fundamental that individuals without pain responses or who have extremely high levels of pain tolerance actually have an increased risk of premature death or serious bodily injury. Because this system is so fundamental to keeping us alive and protective and safe, our body and our mind are not going to leave it down to a simple stimulus response mechanism. Our bodies and our mind have created this complex network to make sure that whenever there is some sort of damage in our body, that these alarm systems fire. And because it's so important, it's created what I like to think of as backup systems, so that whenever there is a potential or actual damage, this alarm system fires. It is an adaptive way to keep us safe, protected, and alive. So one of the things that I'm going to do today is not only talk about the biopsychosocial model of pain, but also talk about how to present it to patients and families so that they can truly understand it. One of the risks when starting to talk to patients and family about incorporating psychology into their pain management plan is they're like, what, you think I'm crazy? You don't think I have real pain? So we need to take a lot of time and effort teaching them about how our body and our mind are connected and constantly interacting. And one of my favorite ways to do this is to talk about the story of the two nails. I'm going to talk about two published case studies just involving different reactions to pain. The first one involves a young construction worker who was going about his day, doing his job, and he inadvertently stepped on a nail. This nail went through the bottom of the boot, came out the top, and understandably, he felt this surge of instant pain. His coworkers saw what had happened and rushed over to help him, brought him to the emergency room. In the ED, they determined that his pain was significant enough that they prescribed him some opioids. And as he was taken back, the physicians cut off the shoe in order to assess whatever kind of damage there was. And what do you imagine they found? Somehow, this nail had actually gone in between his big toe and the toe next to it, and caused almost no tissue damage. So what is going on here? This man was in excruciating pain, so much that they gave him some pretty heavy narcotics. This is a really good example of how our brain has that backup system. It took in information from the environment, his fear of seeing the nail, his eyesight, seeing that there is some huge nail sticking out from his foot where it's not supposed to be there, as well as his coworkers really reacting. And the body, the mind says, okay, maybe I didn't get a really sharp tissue damage response, but there are so many other clues. There is definitely a problem. I need to trigger that pain response. The second story, also a construction worker, getting the sense that this is a dangerous job. And this one involves a man working with a nail gun. He was working away with a nail gun, and somehow the gun misfired, but he saw it go past his face and lodge into the wall over there. And he is like, whew, okay, crisis averted. That could have been really bad. And he went about his day. As the day progressed, he started to get a little bit of a headache. His tooth was a little sore, but he didn't really pay much mind to it and just continued on. Over the next several days, the pain intensified, and on the sixth day, he decided to go into the dentist to check out what was going on with his tooth. The dentist took an x-ray, as they do, and what do you think they found? There was a 4-inch nail going through his jaw, pierced the skull, and was actually touching brain matter. So this individual, on the opposite side, had some very significant tissue damage, but the brain was taking in all of these environmental clues that that's a misfire of that information and everything is okay. The man saw the nail go into the wall. Now, whether he missaw that or there was 2 firings, don't know. But whatever it was, the brain decided, I don't need to pay attention to that and really turn down those pain signals. So there are 4 main types of pain: acute, procedural, perioperative, and chronic pain. Chronic pain is defined as persistent pain or recurrent pain that lasts for 3 months or more. And our kids in the hematology and oncology department really experience all of those. But before talking about that, I just want to note that in the general population, pain in kids is pretty common. That chronic pain is anywhere between 11 to 38% of kids experience chronic pain, and about 5% of those kids experience chronic pain that is really debilitating, that interferes with their ability to go to school, engage in social activities, and function the way that kids should. There's a couple of factors that are commonly associated with that: increased age, being a girl, and also having a parent with chronic pain. And there are likely some genetic, biological, as well as learned behaviors that go along with that. When we look at our kids with cancer, pain is even more prevalent. So depending on the type of cancer, significant pain can be anywhere from 28 to 62% of the kids. About a quarter of individuals receiving chemotherapy experience neuropathic pain, the tingling and stabbing sensation in the hands and feet. 3/4 of kids with amputations experience phantom limb pain. And if there isn't an example of how the body and the mind are interacting for pain expression, I don't know a better one than this, because here, for example, a kid is feeling pain in their foot when no foot exists. There is no tissue there to be damaged, but their brain has decided to send off some pain signals for that area. Unfortunately, once kids are done with treatment, their pain can still continue and last. Survivors, 11 to 44% of survivors experience chronic pain. Again, that's persistent pain for over 3 months. Those with sarcoma are 5 times more likely to have chronic pain compared to some other tumor groups. And then fatigue, emotional distress such as anxiety, depression, anger, low economic status, being single, single, being unemployed, all of those things are consistently related to pain expression and experience of it. In our sickle cell population, pain is obviously one of the big markers of the disease. So in addition to pain crises, 30 to 40% of individuals with sickle cell will develop chronic pain. So that's in addition to those pain crises that land them in the hospital. With this population, you really see the back and forth between the body and the mind, how social and emotional experiences really do interact with pain experience and pain expression. So about a quarter of individuals with sickle cell disease experience depression, and those with depression experience higher levels of higher frequency of pain. Kids with anxiety end up having longer hospital stays and experience more frequent pain. Nearly 3/4 have sleep problems, and those with sleep problems experience, again, more frequent acute pain. And with them, childhood psychological factors are associated with pain frequency. So that means if they have positive psychological factors when they're young, their pain expression and frequency is lower. When they've had a lot of difficulty in early childhood, the pain expression and frequency is higher. So initially, pain was thought to be a one-to-one relationship between tissue damage and pain expression. In the last century, the medical community really began to question that. For example, in the Second World War, a doctor named Melzik really noticed that individuals in the military who came in with very severe problems seemed to express less intense pain than civilians who came in with less damage. And that the community really began to think about, is it really a one-to-one relationship? And all of this culminated in the creation of the biopsychosocial model in 1977 by George Engel. And what it is, and this has also become widely adapted in the last few decades, but what it is saying that pain involves multiple areas. There are biological factors such as genetics, physiology, tissue damage. There are psychological factors such as mood, anxiety, depression, anger, how one thinks and perceives pain, and overall expectations about pain and life in general, and social factors such as economic status, social support, relationship status, all of those. So since then, there has been a good amount of research on pain. And we have learned through fMRI, repeated fMRI studies, that there is no one pain center in the brain. It actually truly is a very complex system. So pain activates multiple different brain regions, including somatosensory cortex, tissue damage. There is the cerebral cortex, which involves how we think about pain. Is this something that is tolerable? Is this the worst experience that we've ever had? Can we get through it, or is this going to be really debilitating? There's the prefrontal cortex, which is about what we pay attention to, our focus. When we pay attention to pain, the experience of it is more intense. So for example, this is one of the things that I say to kids all the time, that have you ever been out playing with your friends, and maybe you were playing soccer, maybe you were going on a bike ride, whatever, and afterwards you came home and you noticed that you've got this like major bruise or this huge cut on your leg, but when that happened you didn't notice it because while your brain decided that soccer, playing with your friends, going on that bike ride was more important than whatever minor issue was going on. So what we pay attention to impacts how much we experience it. Our limbic system, which is our emotional center. So when you're in a good mood and feeling happy, the pain experience is less. when you are angry, sad, anxious, the pain experience can increase. If you think about if you've ever woken up in the morning in a really bad mood and maybe slammed your finger in a drawer or stubbed your toe, it really hurts. But if you're with your friends and you're laughing and you're having a good time and you stub your toe, the exact same damage, you laugh it off and you really don't notice it so much. But within the limbic system, two of the big areas that are affected, it's not limited to these, but the amygdala, which is again, another big warning, fear, anxiety center, lets us know when there's problems, and hippocampus, which is related to the memory of pain. So part of whether or not we need to react to pain is filtered through our past experiences. So if we have had more pain in the past or more unpleasant pain experiences, our mind is actually going to become more sensitive to it. We don't habituate to pain, we don't get used to it. That memory actually makes it more likely to trigger quicker. So again, gaining buy-in is really, really important through stories, through examples, through using technical language. I use a lot of technical language even with my little kids. But if you'll humor me for a minute, this is one of my favorite exercises. So I want you to think of one of your favorite foods. It can be anything. Now, I want you to imagine that you have your favorite food on a plate or a bowl right in front of you. And really look at it. Notice the colors of it, the shape of it, the different textures. And really, really try to picture that yummy, good, favorite food right in front of you. I want you to imagine bringing that plate or that bowl up to your nose, close to your face, smelling what it smells like, noticing the temperature of the food against your skin, and really taking in and imagining those different aromas of the food. Now imagine putting your plate or your bowl back down, taking your knife or your fork, or if it's finger food, just picking it up and slowly bringing it to your mouth. I want you to imagine putting that food in your mouth, not chewing yet, letting it sit on your tongue. Notice the different textures of it. Notice the flavors, how it all melds together. Now slowly take a bite, chew that, and swallow it down. All right, and then I say to the kids, now tell me, is your mouth watering? And they, of course, say yes. I've only, in all the years that I've done this, I've only had one kid who said his mouth wasn't watering. I think he was just giving me a hard time. But then, do you know why your mouth is watering? What the purpose of your mouth watering? And I tell them the saliva, your mouth watering, is actually the very first step in digestion. It is the first step to help break down those foods and get it ready for your belly so that your body can take all those good nutrients from the food and use it for the energy in the food that it needs. So what you have done is, with your imagination, you have caused a physiological response. Your body is preparing to take in food that only exists in your imagination. It isn't real. So with your mind, you have caused a physiological response, a physical response in your body. So if you think about being able to, if you can do that, you can learn to harness that brain power so that you can have an influence about how your brain reacts to pain. You can have a chance to alter that physiological response to different things going on. I apologize that this paper is a little bit blurry, but what this is it's an article in Pediatric Child Health from 2022 talking about best practices with pain management for kids. And what it says, and what is widely accepted, is that an interdisciplinary approach is better than any single standalone therapy. And that interdisciplinary approach involves pain medicine, rehab therapies like physical therapy and occupational therapy, and pain psychology. And of note, the primary goal is not the absence of pain, but actually to improve quality of life and functional ability, um, and to help patients and families understand that goal and accept that goal. So I'm going to talk about the psychosocial aspects of the biopsychosocial model. I will leave the biology to the medical professionals. Cognitive behavioral therapy, or CBT, is one of the main evidence-based treatments that are used to help reduce pain and with behavioral pain management. It is aimed at modifying social, environmental, and behavioral factors to alleviate or reduce pain. And I'll talk about each of these principles a little bit more, but the way that it works is it teaches kids to react to and think differently in response to pain, to teach them better coping mechanisms, to help them shift their focus away from pain. One of the things that happens in chronic pain is that becomes the center of a kid's life, and they are evaluating everything through pain. Am I going to have pain today? Can I do this? Am I not going to have pain today? Those kinds of things. And so through CBT, we're teaching them to shift that focus into other areas so they can incorporate more positive elements into their life. Positive elements, positive activity increases mood, involves the limbic system, makes that pain experience less. We need to eliminate unhealthy coping strategies that over time kids naturally have likely learned some things that might work in the moment, but over time can be harmful or actually reinforce some of that pain. Parents need to be involved. Without parent buy-in, this is not going to be successful. So like kids, the parents, are going to need to learn to alter the way that they think and how they respond to their kid with pain. And we need to address any social or school problems. School can be a vicious cycle for a lot of kids with pain. So say you've got a kid with sickle cell who had a crisis and is in the hospital, also experiences chronic pain in between crises. They're in the hospital, they miss school, they get behind on their schoolwork, they are discharged, they go back to school, they're not in top-notch shape, they're still experiencing some of the remnants of the crisis, and then they're just regular pain. So not quite as focused as they would be. They have the stress of having to do their current schoolwork when they're not feeling good, as well as the added schoolwork of trying to make up what they missed. To add to this, it is unfortunately quite common for schools to not have a good understanding of pain, of sickle cell, cancer pain, and to assume and even tell the kids that they are exaggerating, that they are using it as a crutch, they're not applying themselves that they should. So then this becomes very stressful because there is extra work that they have to do. They're not feeling good. They are in an environment that is unsupportive. So we know stress increases the experience of pain. So school then can be a source of stress, which can increase pain, which can lead to missed school, which can increase pain. So without involving their social circles, we're setting these kids up to have a harder time. These are just two meta-analysis studies that really show that CBT and psychotherapy can be very helpful in reducing pain. So all of these showed about a 50% reduction in pain expression. All right, so I'm going to talk about more specifically about some of the interventions. The behavioral interventions are the ones that I always start with. And again, I always spend a good amount of time talking about how and why these interventions work, reminding them of that mind-body connection, and specifically how one intervention is going to help them with their pain. Because otherwise, it's just a whole bunch of psychobabble hogwash. They're like, okay, whatever. The very first one that I always teach is diaphragmatic breathing. And this one, I typically, when I'm introducing it, I make a joke because inadvertently, at some point during a kid's life or of treatment, they have been told that when they've got pain, they need to take deep breaths and just breathe through it. And unfortunately, they are often not told how to do that because it's not regular deep breaths or why it works. So they've tried this technique, it hasn't worked, and it can feel very dismissing and invalidating over time. So I teach them that this is a special kind of breathing. With little kids, I call it magic breathing. And it feels very strange to do it first because it is not a normal, typical way that we breathe. So for example, when kids are take a deep breath or told to take a deep breath, typically they do it in their upper lungs and just way up here. And unfortunately, that's not the kind of breathing that is really going to help bring down those pain cycles. Instead, they need to breathe in where it is pushed down into the bottom of their belly. It might feel like they'll see their belly go up and down. I try to tell them to imagine a balloon being filled up. And it is challenging for kids to do this because it really is an unnatural or not typical way of breathing. And exhaling, the exhale is also a little bit different because you're trying to push what it feels like all of the air out of your body. So it feels like your body is empty and deflated and there's no air left in it. When I teach kids how to do this correctly and they try a couple, often I get these amazed expressions afterwards of like, wow, that actually helped, or whoa, that's really relaxing. So they need to know that deep breathing is a very specific kind. I also connect this with the physiology, and that this type of breathing, the one in your belly, not the one up here, triggers the centers in your brain that are involved with reducing that pain response. Older kids, I'll tell them that the parasympathetic nervous system gets triggered and tells the mind that everything's okay. With little ones, I might just say that it's tells the brain everything is peachy and it can turn down some of those alarm signals. Progressive muscle relaxation and imagery are often aimed at physical muscle relaxation. And again, I need to pair this with the whys. I'm not just trying to make them feel relaxed, but there is a direct connection between what we're doing and pain management. So, as an example, let's say that a kid has broken his leg. This is what I say to them. Your leg muscles are going to tense around that broken leg in order to keep everything protected and to try to keep that bone in place until there can be some sort of help. So that muscle tension is one of the things that triggers the pain areas in your mind and saying that we need to keep those alarm bells going so that you don't ignore this pain and you make sure to take care of it. So when you can physically force your muscles to relax, you are sending signals to your mind, to your brain, that the problem is less acute, less severe, and some of those pain signals can be reduced. Distraction is a very real and important technique for pain management. Remember, that's the prefrontal cortex of what we're paying attention to. That paying attention to pain, if it's the center of our life, then those signals are going to be increased. This one, there are times when there's some misunderstanding with distraction that on numerous times I have had parents and on occasion staff members say that a kid in the hospital they're exaggerating their pain, they're faking it. And their evidence is that when the kid is playing their video games, they can focus and they're smiling and they're okay. When they're chatting and talking to their friends, they're laughing and much more relaxed and having a good time. But then the doctor comes in and starts to asking them, and all of a sudden the pain is 8 out of 10 and they can't do anything. Or physical therapy comes in and tries to get them out of bed and it's just too much. So obviously they must be faking. But not necessarily, because distraction takes the attention away and can reduce some of those pain signals. Laughing and hanging out with your friends can increase positive feelings, such as that limbic system, and can also reduce that experience of pain. So there is a real physiological response that happens to that distraction. And when it's taken away, when that focus is back on the pain, the experience of pain might actually go up. Related to that, making sure to plan pleasant activities. Pain can become so central that kids stop doing the things that they enjoy. We want to make sure that we want to bring that back in to improve that quality of life and to make sure there's other things for them to focus on. And activity pacing related to this, one of the tendencies with chronic pain is to lie low when they're not feeling very well. And then on that day when things are okay, all of a sudden to do everything that they wanted to do, completely overdo it, and the next day have significantly more pain than they would have otherwise. So this is about teaching them to be realistic about how much they can do so that they can do things more consistently instead of these just bursts and absences. Involving parents is very important. Just like kids, parents are going to often have misconceptions about chronic pain. That, like kids, they may feel that if you start mentioning psychology, that all of a sudden you think their kid is lying or faking it, or you're going to stop giving them medications. That when you talk to them about interventions, those engaging in activities, one of the tips is to not check in about pain and ask them how they're doing. Those things can seem very counterintuitive to a parent. So a natural reaction to an acute event is to really give the kid a lot of attention, to help them relax, do things for them, make them feel comfortable, check in, see how they're doing. And that's a kind of an instinctual parent response. But that isn't so helpful when we're dealing with chronic pain. When a parent is checking in all the time, it brings that focus to pain and actually can reinforce it. Kids can inadvertently learn that there's a lot of attention to be got around pain expression. Encouraging a kid to rest and not engage in things might seem like the right thing to do at the time, but again, what that does is it takes away those enjoyable activities. It increases the thought that pain is debilitating and overall isn't helpful. So the misconceptions that parents have need to be acknowledged and addressed also. The cognitive part in CBT involves teaching kids to identify their unhelpful thinking. There are many terms that pretty much mean the same thing: thinking mistakes, thinking errors, maladaptive thoughts, automatic negative thoughts. All of these really just mean that a kid is thinking negatively in an unhelpful way about their pain experience. These kinds of thinking errors are harmful because they keep a child focused on pain. They make our perception and experience of that pain worse, keep the child from incorporating and enjoying other things other than the pain because they're so hyper focused on it. And it contributes to the idea that they have no control and that they're helpless and that they are just at the mercy of whatever their pain decides to do. Pain catastrophizing in particular is a significant predictor, not just associated with, but a predictor of pain, functional disability, and health-related quality of life. Pain catastrophizing is thinking in incredibly fatalistic and negative terms about pain. And it's common. Things like starting to feel pain. This is the worst thing ever. I know I'm going to end up in the hospital. I'm not going to be able to see my friends. I'm going to miss school. Because I miss school, I'm going to fail my test, and this is the worst thing that ever happens. And why me? And what did I do to deserve this? And this is ruining my life. So what CBT does is it teaches kids to identify when they're thinking in those negative or unhelpful ways, and to restructure the way that they're thinking into something that is more realistic and adaptive. Now, I'm not talking about positive thinking. The idea, kind of the misconception of what positive thinking is drives me crazy. That this isn't about being Pollyannish and overly positive and everything is going to be just fine. I don't have to worry about anything because these kids, things aren't always fine. And sometimes they do have to worry about things. And it's not helpful to deny the reality of their experience. So instead, we want to have something that's realistic and adaptive. So we may look at that, I'm going to end up in the hospital and this is ruining my life, and say, okay, how can we rephrase that? I'm starting to feel some pain. I really don't like this. I hope I'm not going to end up in the hospital. If I do end up in the hospital, I know that I can get through it because I have before and I will again this time. Another evidence-based intervention for pain management is mindfulness. Mindfulness is one of those terms that is completely overused and misused. What it actually is being aware in the present moment of our thoughts, feelings, sensations, and being aware without judgment. That's the hard part. So, not saying whether those thoughts, feelings, sensations are good or bad, just noticing that they're there, not trying to do anything about them or having the expectation that we have to fix something, but learning to just notice and let it be. What this does is it allows us to have a pause, so to speak, that keeps us from being reactive to whatever our thoughts, feelings, sensations are, and gives us a moment to decide how we want to respond, what we want to do with that, as opposed to just reacting and not having any sort of influence over. There is an abundance of evidence that these techniques are helpful with anxiety, depression, stress, pain, that a continued mindfulness and meditation practice over time can actually alter and change the brain. So it changes our prefrontal cortex, changes the way that we pay attention, alters the limbic system in particular. There have been studies that shown that it actually shrinks the amygdala. And again, the amygdala is one of those danger systems in the brain. And it increases functional ability and decreases pain experience and improves pain tolerance. It is a simple but beautiful and powerful technique that kids can learn to manage their pain. And again, it's very important for kids and adults to talk about how something as simple as noticing can actually change the physical body. They need to have that idea reinforced that these are connected. Our head, our body connected. They're always interacting 100% of the time. So, for example, an individual without mindfulness, they notice some leg pain. And the natural response is to clench up those muscles. Again, muscle tension is a natural response to pain. To notice it, to have the knee-jerk thoughts of, oh my gosh, not again. Why does this always happen? To feel angry, to feel frustrated, to have that sense of hopelessness, and really be a hyper-reactive without control, letting that pain sensation dictate how we feel, what we do, what we think. What mindfulness does is the individual notices that pain and they have learned to notice without reacting. So notice it, take that moment to breathe, to focus on breath, to perhaps massage the leg, to try to relax the muscles, to stop fighting against it, and to take that pause to decide how they're going to react to this. It helps to diminish some of that catastrophic thinking, which is highly associated with pain expression, and just the overall reactivity to it. So I want to close with just, again, emphasizing how in the olden days that we used to think that things were mental or things were physical. There are a lot of our patients are sophisticated enough to know that our head and our body are constantly interacting, but there's a large population out there that don't have that level of sophistication. And we need to constantly teach them and remind them. For example, I fairly recently had a teenager who was in the hospital, significant amount of pain, and it was a bit more pain than was expected for what was going on with him medically. And a staff member, I wasn't there for it, but his interpretation of what the staff member said was that he was because of his stress or his mood, he was really causing all of this pain to happen. Okay, so yes, those two things are most likely related. However, the way that he took it, when I came in, he asked me, am I going to go to the mental hospital because I am just imagining this? We can't assume that our kids and our families are going to have this basic understanding of this connection. And we need to spend a good amount of time making sure that they do understand. And for us providers who are helping manage that pain, to remember to always incorporate all of these different biological, social, like school, and psychological factors, and approach pain management incorporating all of these factors, because that is the way that we are going to be the most successful. All right, so thank you all for listening. And if you have any questions, please just submit in the chat, or you can raise your hand. Let me stop sharing this. All right, well, thank you guys. And if you have any questions in the future, please feel free to contact me, or you can contact Sharon Botros. Thanks.